Welcome to the Anesthesia and Perioperative Medicine channel. Benvenuti al canale dedicato ad anestesia e medicina perioperatoria. आज anesthesia और perioperative medicine channel पर हमारे साथ जुड़ने के लिए धन्यवाद. Today, we are diving deep into what is, without a doubt, one of the ultimate challenges in our specialty, the perioperative management of pheochromocytoma. This is so much more than just a routine case. It is a high-stakes, physiological chess match where every single decision, every drug we choose, can tip the scales between a smooth, successful surgery and an absolute catastrophe. So let's break down exactly how we can navigate this challenge and master it. So here's our roadmap for today's deep dive. We're going to start with the why, getting a solid grip on the underlying science of these tumors. Then we'll get practical with the how, our crucial preoperative game plan. From there, we'll jump into the OR for the when, managing that moment-to-moment hemodynamic chaos. We'll then debate the which, looking at the hard evidence behind our anesthetic choices. And finally, we'll zoom out and look beyond the OR at long-term care. Let's get right into it. All right, first things first, before we can even think about managing this condition, we have to truly understand the beast we're dealing with. This section is all about getting back to basics, the fundamental pathophysiology of pheochromocytoma and paraganglioma, and the incredibly precise biochemical tools we use to nail the diagnosis long before that patient ever sees the inside of our operating room. So what is a PPGL at its very core? Well, you can think of it as a tumor that has completely hijacked the body's fight or flight system. It grows from chromaffin cells, the very cells that are supposed to produce our stress hormones. If the tumor is in the adrenal medulla, we call it a pheochromocytoma. If it's outside the adrenal, in the sympathetic ganglia, it's a paraganglioma. But honestly, the location doesn't change the main problem. You have a rogue factory that is just pumping out an uncontrolled, massive flood of powerful hormones like norepinephrine and epinephrine. And this is where it all begins, this biochemical assembly line. Under normal circumstances, our body takes the amino acid tyrosine and through a series of elegant steps, converts it into dopamine, then norepinephrine, and finally epinephrine. But in a patient with a PPGL, this assembly line isn't just running, it's in a state of unregulated, chaotic overdrive, 24/7. This is the source of that hormonal tsunami we have to prepare for. So how exactly does this flood of hormones cause so much chaos? It's all about the receptors they hit. First, the beta receptors get slammed, which whips the heart into a frenzy. It's beating faster and squeezing harder. At the exact same time, alpha-1 receptors get stimulated, and that clamps down on blood vessels everywhere, causing this intense, body-wide vasoconstriction that sends blood pressure through the roof. Now, there is a built-in safety switch, the alpha-2 receptor, but it is just completely overwhelmed. It doesn't stand a chance against the sheer volume of catecholamines pouring out of that tumor. And if we zoom way in, down to the microscopic level, you can see the problem right here. This is an electron micrograph of the tumor's chief cells. And look at them. They are absolutely stuffed with these dark, dense neurosecretory granules. You can think of each one of those granules as a tiny biological bomb, packed with catecholamines just waiting to be released into the bloodstream at the slightest provocation. And that becomes incredibly important for us to remember during surgery. Now, here's where it gets really interesting, especially for us as anesthesiologists. These tumors often don't show up alone. A huge percentage of them are tied to inherited genetic syndromes. Take von Hippel-Lindau disease, or VHL, for example. These patients are also at risk for things like renal cell carcinoma and, critically, hemangioblastomas in the brain and spinal cord. Now, why does that matter to us? Well, imagine you're thinking about placing an epidural in a patient with an undiagnosed spinal hemangioblastoma. The risk of causing a catastrophic bleed is enormous. So recognizing these syndromes isn't just academic trivia. It directly and fundamentally changes our anesthetic plan. So what does this actually look like when a patient presents? Well, the classic triad that we all memorized is episodic headaches, sweating, and tachycardia. But in the real world, the picture is often much fuzzier. Patients might complain of what feel like panic attacks, severe anxiety, palpitations, or sometimes just really vague things like fatigue and unexplained weight loss. The key is that these symptoms are often paroxysmal. They come and go in spells, sometimes triggered by something as simple as changing position or eating certain foods. Okay, so this brings us to a really key diagnostic question. If the whole problem is too much epinephrine and norepinephrine, why is the gold standard test to look for their breakdown products, the metanephrine's? Well, the answer lies in a quirk of the tumor's own metabolism.
You see, the release of the actual catecholamines can be very brief, very episodic. You could easily check a plasma epinephrine level between spells and get a completely normal result, a false negative. But the conversion of those catecholamines into metanephrines happens continuously inside the tumor cells themselves, and these metabolites then leak out into the bloodstream at a nice, steady rate. So it's like looking for the constant smoke from a fire, rather than trying to catch a fleeting spark. It gives us a much more reliable signal that the tumor is there. And this table right here is the proof in the pudding. Just look at the diagnostic performance of plasma-free metanephrines. The sensitivity is approaching 100%. That is absolutely incredible. It is, without a doubt, the single best test we have to rule out a PPGL. Compare that to measuring plasma catecholamines directly, which is way less reliable because of that episodic secretion we just talked about. The takeaway here is crystal clear. If you have any suspicion of a PPGL, testing for metanephrines is the way you get your answer. Okay, so once the labs confirm our suspicion, the next mission is to find the tumor, or tumors. We start with CT or MRI, of course, but functional imaging like this amazing gallium-68 dotatate PET CT scan is just invaluable. It works because these tumors often have somatostatin receptors on their surface, which this tracer homes in on. This kind of scan is fantastic not only for pinpointing the primary tumor, but also for sniffing out any multifocal or metastatic disease, which, as you can imagine, completely changes the surgical plan and the patient's prognosis. All right, we've found the tumor. Now, how in the world do we get this patient safely to the operating room? With that diagnosis confirmed, the entire focus of the team has to shift to one single critical goal: preparing the patient to prevent a hemodynamic nightmare once they're on our table. So this is the crucial point. We're facing a two-headed monster. Taking an unprepared patient to surgery is, to put it bluntly, courting disaster. Any stimulus, our laryngoscopy, the surgical incision, and especially when they touch the tumor, can trigger a massive catecholamine surge, leading to a hypertensive crisis, a stroke, or an MI. But the danger doesn't stop there. The second the surgeon ties off the tumor's vein, the source of all those catecholamines is gone. And that creates the perfect storm for profound refractory hypotension. Our entire preoperative strategy is built around taming these two opposing forces. And that preparation is a meticulous, step-by-step, absolutely non-negotiable process. Let's walk through this timeline. It all starts 10 to 14 days out from surgery with the cornerstone of management, alpha-adrenergic blockade. This is what controls the blood pressure and, just as importantly, allows the patient's chronically constricted vascular system to finally relax and expand. Now, only after we've established a good alpha blockade, and I cannot stress this enough, only then can we add a beta blocker to control the heart rate. Starting a beta blocker first is one of the classic mistakes. It leads to unopposed alpha stimulation and can trigger a lethal hypertensive crisis. All the while, we're pushing salt and fluids, culminating in IV hydration the night before to make absolutely sure the tank is full before they even get to the OR. And now, we're in the operating room. This brings us to the when. Those critical moments of intraoperative control. All of our careful preparation is about to be put to the test. The best way to think about this period is to break it down into 4 distinct stages, because each one comes with its own set of predictable challenges. Thinking about the case in these 4 stages, induction, dissection before they get to the tumor, the actual tumor manipulation, and then post-resection is our key to staying ahead of the curve. It allows us to anticipate what's coming next and proactively manage those wild hemodynamic swings. Each stage presents a very predictable set of risks, and each demands its own specific management strategy. And this image really just drives home the reality of what's happening on the other side of the drape. You can see these tumors are often incredibly vascular and nestled right up against major vessels like the aorta or the vena cava. The surgeon has to be so meticulous to minimize bumping or squeezing that tumor, which would cause an uncontrolled catecholamine release before they have control of the adrenal vein. So in these first couple of stages, the biggest hemodynamic risks actually come from us. The simple act of laryngoscopy and intubation is a massive sympathetic stimulus. But even beyond that, we have to be so careful about the drugs we choose. Because some of our most common everyday anesthetic agents are like throwing gasoline on this fire. Our drug choices here are absolutely critical. Let's run through the list of agents we should be extremely cautious with. Desflurane can directly stimulate the sympathetic nervous system. Ketamine is a direct sympathomimetic, but the one I really want to highlight is succinylcholine. This one is particularly sneaky and dangerous. Just imagine what those muscle fasciculations are doing. They are physically squeezing the tumor like a sponge, forcing a huge bolus of catecholamines right into the circulation at the worst possible moment, induction.
It's a disaster we have to avoid. And as you can see, we have plenty of great, hemodynamically stable alternatives for all of these.
Now, when the blood pressure does spike, and trust me, it probably will, we need to have our pharmacological crash cart ready to go. Our mainstays for rapid control are short-acting, easily titratable vasodilators like sodium nitroprusside or nicardipine, which you can see here. An IV alpha blocker like phentolamine is great because it directly attacks the alpha-1-mediated vasoconstriction, and a short-acting beta blocker like esmolol is absolutely essential for controlling tachyarrhythmias, but I'll say it again, only when you are completely confident that your alpha blockade is solid.
Stage 3. This is the crescendo of the storm. This is when the surgeon is directly handling, dissecting, and mobilizing the tumor. This is the period of maximal surgical stimulation, and it can trigger a biblical-level release of catecholamines, often leading to the most severe and frightening hypertension of the entire case. This is when clear, constant communication with your surgeon is absolutely paramount. And then, in an instant, everything changes. The moment the surgeon puts a clamp on that adrenal vein, the tap is turned off. And the sudden withdrawal of that massive catecholamine infusion, combined with the alpha blockers still on board and our vasodilators still running, creates the immediate risk of a profound, precipitous crash in blood pressure. Our response in this moment has to be immediate and decisive. First, you've got to kill all your vasodilators. Second, open up the fluids and start resuscitating aggressively. Third, you need to be ready to start vasopressors like norepinephrine without any delay to restore that vascular tone. And critically, we have to remember, that patient's heart has been swimming in a toxic bath of catecholamines for months, maybe years. That sudden drop in afterload can unmask a stunned, weakened myocardium. We have to be incredibly vigilant for signs of acute heart failure. Okay, so all of this hemodynamic craziness brings us to a really pivotal question about our anesthetic technique, especially when we're talking about open resections. We know how to react to the swings, but does our choice of anesthetic, specifically whether or not we add an epidural to the mix, actually change the risk profile? Let's take a look at the evidence. The theoretical argument for an epidural is really compelling. It could provide awesome intraoperative stability by blunting the stress response, and it offers superior postoperative pain control. But on the flip side, it also causes a chemical sympathectomy, which could make that post-resection hypotension even worse. A really important retrospective study from the NIH decided to tackle this exact question. So let's look at their raw data. Your eyes are immediately drawn to that bottom row, right? Look at the rate of postoperative hypotension. In the group that got an epidural, it was almost 59%. In the group that didn't get an epidural, it was only 25%. With a p-value of 0.003, that is a highly significant difference. That's a huge signal right off the bat. The study also dug a little deeper and found that the patients who did become hypotensive generally had higher baseline normetinephrine levels and more tumors, basically markers of a higher overall catecholamine burden. And look at this. They needed way more IV fluids post-operatively, which led to more weight gain. That's a clear clinical sign of just how much resuscitation they required to keep their pressure up. But honestly, this is the real smoking gun, the multivariable analysis. This is the statistical technique where they control for all the other variables to isolate what the true independent risk factors were. And 3 things really stood out as significant predictors of post-operative hypotension. And the strongest predictor, by far, was the use of epidural anesthesia. The hazard ratio was nearly 3.5. Let that sink in. After they accounted for everything else, the patients who received an epidural were 3.5 times more likely to develop postoperative hypotension. This wasn't just a simple association. The data showed it was an independent risk factor. The study's authors really didn't mince words in their conclusion. They state very clearly that epidural anesthesia is an independent risk factor for this very specific, very dangerous complication. Now, this doesn't mean you can never use an epidural, but it does mean we have to approach that decision with extreme caution and a very clear-eyed understanding of this heightened risk. So ultimately, this leaves us with a classic clinical trade-off. It's a real dilemma. If you go with general anesthesia alone, you make that post-resection phase much simpler to manage, but you might have to deal with more labile hemodynamics intraoperatively and then rely on IV opioids for pain control. If you add an epidural, you get potentially smoother intraoperative control and amazing analgesia, but you do so at the cost of a significantly increased risk of severe postoperative hypotension. The decision really has to be individualized, based on the patient, the tumor, and a frank, shared discussion about these risks and benefits. And finally, our job as perioperative physicians doesn't really end when we drop the patient off in the PACU. Understanding the long-term management of this disease is absolutely essential if we want to provide truly comprehensive care and counsel our patients appropriately.
Surgery is the primary treatment, but it's not always a one-and-done cure. These tumors can and do come back. That is why lifelong annual surveillance with metanephrine testing is mandatory. And equally important, given those strong genetic links we talked about, genetic counseling isn't just a good idea, it is an absolute necessity. Finding a genetic mutation doesn't just impact our patient, it has profound implications for their parents, their siblings, and their children. And this leaves us with one final forward-looking thought to chew on. Right now, we tailor our anesthetic based on things like biochemical activity and tumor location. But as our understanding of the specific genetic drivers evolves, for example, we now know that an SDHB mutation carries a much higher risk of aggressive metastatic disease. Will we start to personalize our anesthetic plan even further? Could the molecular signature of a tumor one day tell us which anesthetic technique is safest? That is the really exciting future of perioperative medicine for this incredibly fascinating and challenging disease.